everyone. My name is Bernaja, and I'm going to be discussing triple negative breast cancer, or TNBC, with a particular focus on its impact on Black women. And so, although TNBC accounts for only 10 to 15% of breast cancers, it is one of the most aggressive subtypes with higher recurrence rates, early metastasis, and poor survival outcomes in comparison to other forms of breast cancer. Um, Black women are unfortunately disproportionately affected by TNBC, experiencing both a higher incidence and a higher mortality rate because of a combination of tumor biology and health care inequities. Today, I'll discuss the disease, its progression, current treatment, symptom management, psychosocial impacts, and the importance of early palliative care and how the critical role that nurses play in all of that. And so here I have some our learning objectives. Okay. I have some learning objectives, and I hope that by the end of the presentation, you will be able to do the following. And so, what is triple negative breast cancer? It is a invasive breast cancer subtype that lacks the expression of estrogen receptors, progesterone receptors, and HER2 receptors. And this is significant because it makes hormone therapy and HER2 targeted treatments ineffective. These treatments are typically things that would be considered highly effective for other more common types of breast cancer. Because of this, chemotherapy remains the foundation of treatment. TNBC is highly aggressive with rapid tumor growth, early metastasis, and greater risk of recurrence during the first 3 to 5 years after diagnosis. And some key risk factors include younger age, BRCA1 mutations, obesity, and family history. In addition, being of Black race. Importantly, race itself is not the cause of poor outcomes. Instead, it's the biology of the tumor interacting with healthcare access and broader social inequities that create the issue. For nurses, understanding TNBC that is essential for educating patients, coordinating genetic counseling when appropriate, preparing them for treatment, and providing emotional support throughout the disease process. And so, although TNBC represents only 10 to 15% of breast cancers, Black women are nearly twice as likely to be diagnosed with this subtype and experience significantly higher mortality rates than white women. While aggressive tumor biology contributes to this, disparities are also driven by a delay in screening, limited access to specialty oncology care, financial burdens, and most importantly, most significant in my opinion, is the underrepresentation in clinical trials. And so nurses can help reduce these disparities by providing culturally responsive care, building trust, advocating for equitable access to treatment, and helping patients navigate barriers to care. And so, after diagnosis, patients are typically undergoing staging, which helps guide the treatment planning. And so, most patients with localized TNBC begin with a neoadjuvant chemotherapy before surgery, which helps shrink it and also monitors its response to chemotherapy. And following treatment, many patients are entering remission or survivorship. But they may continue to experience fatigue, neuropathy, cognitive changes, and fear of recurrence. Unlike many other breast cancers, TNBC has the highest risk of recurrence within the first 3 to 5 years. So if recurrence does occur, it commonly metastasizes to the lungs, the liver, bone, and even the brain. And so the nursing role throughout this trajectory is evolving. During active therapy, it is treatment education and symptom management. During remission or survivorship, it's surveillance. And as the disease progresses to an advanced stage, it is comfort-focused care. And so, as far as treatment approaches, I actually compared treatment recommendations published 10 years apart. The first being Wahab and El Hadid in 2015, and the more recent one being the National Cancer Institute's guidelines in 2025. And so, despite advances in oncology, surgery, and surgery, chemotherapy, and radiation actually remain the foundation of treatment for localized TNBC. Some things that has changed is the availability of more personalized therapies. And so current guidelines now include immunotherapy, PARP inhibitors for patients with BRCA mutations, and antibody drug conjugates for those with advanced stage disease. Now, for nurses, these advances mean that monitoring chemotherapy toxicities are not, are that means that we're not only monitoring those chemotherapy toxicities, but we're also learning about those newer adverse effects that come along with the newer guidelines. And as far as symptom management in relation to cancer care, even with improved treatments, patients will experience symptom burden, unfortunately. One being fatigue. It's one of the most common symptoms with cancer. And as nurses, we can encourage things like energy conservation techniques, light physical activity when possible, and also evaluating and assessing for any reversible causes of fatigue, such as anemia or nutritional imbalances. Another one is pain. Pain, unfortunately, is a very common symptom across cancer, and it should be routinely assessed with an appropriate pain assessment tool. And the World Health Organization, or WHO, has created an analgesic ladder that is used as a great guidance for managing cancer pain, progressing from non-opioid medications such as NSAIDs to opioids such as morphine or fentanyl when clinically appropriate. In addition, adjuvants or co-analgesics are used across the ladder to enhance pain relief. And another big symptom for cancer patients are emotional distress, including anxiety, depression, and fear of recurrence, all very common. And as nurses, we play a key role by screening for distress, providing emotional support, and connecting patients with the appropriate resources. And so effective symptom management is very important because it can improve quality of life and help patients better tolerate treatment. Now, TNBC affects far more than physical health. Patients will experience anxiety, changes in body image, fertility issues, uncertainty about their future. Many women serve as caregivers, decision makers, or financial providers within their families. And more specifically for Black women, these responsibilities are often compounded by cultural expectations, multi-generational caregiving roles, and existing social economic inequities. And as a result, cancer diagnosis can affect not only the patient, but also the stability and well-being of the entire household. And so family caregivers are also at risk for emotional distress, burnout, and financial hardship, making a caregiver assessment a very important nursing responsibility. We also have financial toxicity being another major challenge, and nurses can help identify barriers early and connect patients with the appropriate resources, such as social workers, nurse navigators, or financial assistance programs. Now, one way to support both patients and their families throughout this journey is through early palliative care. And now, palliative care is something that is often misunderstood as being only for end of life, when it should begin at diagnosis for patients with serious illnesses, such as TNBC. It works alongside curative care or disease-directed treatment by managing symptoms, providing emotional support and spiritual support, and facilitating goals of care, discussion, and improving quality of life overall. Now, as the disease progresses, palliative care will become increasingly important. Now, hospice is introduced when the focus shifts from disease-directed treatment to comfort-focused care. And so, because nurses spend most of the time with the patients and their families, we are playing a very critical role in advocating for early referrals, supporting shared decision making, and ensuring care aligns with each patient's values. And now, caring for patients with triple negative breast cancer requires a robust collaboration amongst many different teams, oncologists, surgeons, nurse navigators, social workers, dietitians, chaplains, counselors. Each of these disciplines address a different aspect of care, but oncology nurses, more specifically, often serve as the central point of communication by coordinating care, educating patients, monitoring treatment effects, managing symptoms, and advocating for the patient's needs. Now, some key nursing takeaways in future directions. Triple negative breast cancer, as I discussed, is an aggressive disease that disproportionately affects Black women because of both biologic and systemic factors. Nurses are playing a very vital role by providing evidence-based education in managing symptoms, coordinating interdisciplinary care, and promoting equitable access to treatment, and integrating palliative care early in the illness trajectory. Continued efforts to improve access to clinical trials, genetic counseling, and culturally responsive care remain essential for reducing disparities. And to end, I'd like to say improving outcomes for Black women with TNBC requires more than advances in treatment. It requires more access to care and a commitment to improving quality of life across the illness trajectory. By providing evidence-based, culturally responsive, and compassionate nursing care, we as nurses can improve both survival and quality of life for the patients and the families we serve. Thank you for your time, and those are my resources.